really pleased to be here with everyone gathered to support funding for the National Institutes of Health. I'm also gratified that Senator Ben Cardin was able to be with us here today, and I really applaud his efforts to highlight the importance of addressing health disparities for the citizens of Baltimore, for Maryland, and for the nation as a whole. I've devoted my career to the study and elimination of health disparities in urban settings, and I became interested in this for several reasons. First, I was born in Liberia, West Africa, where I was very aware of how fortunate I was in terms of the quality of life that I had and the health that I had. My parents were both educated professionals, but most of the children that I saw on the streets when I grew up were not so lucky. I came to the United States in 1980 to complete my education here and to escape the violence that was going on in my home country. And my family after that immigrated here. After graduating from college, I did my residency at the University of Maryland before doing a research fellowship and joining the faculty at Johns Hopkins. During my residency training, the patients that I saw in Baltimore were not that different from many of the people that I saw in Africa. The problems that I saw them face included financial struggles, neighborhood safety issues, and reduced job opportunities. I saw communication problems between them and the doctors that led to problems in diagnosis and treatment. And I became determined that I would not only be a good doctor, but that I would conduct top-notch research to better understand the problems of urban populations and to identify solutions to those problems. Over the course of my career, I've been fortunate to be supported by government and private funding. But without the support that my colleagues and I at Johns Hopkins received from the NIH, we would not be able to do the work that we're doing today. I'm currently the principal investigator of an NIH grant, which is $9 million over 5 years, that has enabled us to create the Hopkins Center to eliminate cardiovascular disparities. As you heard earlier, the health status for Americans has improved overall. However, still too many Americans don't have the same opportunities to be healthy as others. Nowhere is this more evident than in Baltimore City, where there's a 20-year gap in life expectancy between those who live in more affluent neighborhoods and those who live in poorer areas of the city. And you heard from Senator Cardin about how much health disparities cost us, over $50 billion in medical care costs, but also over $250 billion lost annually due to illness or premature death. The death rate from cardiovascular disease is astounding. 2,200 Americans die every day from cardiovascular disease. And the death rate from cardiovascular disease is 1.5 times higher in African American men than in white men. And I know this only too well because I lost my father to cardiovascular disease at the age of 56. If we could eliminate cardiovascular disparities, we would cut deaths by heart disease by 5,000 every year and by 2,000 for strokes every year in African Americans. So there's an urgent need to integrate the best known evidence about heart disease and to identify sustainable strategies to overcome disparities and to improve hypertension control, which is the major contributor to cardiovascular disease mortality. My colleagues and I have found in our work funded by the NIH that diet, access to healthy food, what does or does not happen in the doctor's office or in the patient's home is what contributes most to disparate health outcomes. At our new NIH-funded center, we're using community-based participatory principles to build ties among researchers, community members, healthcare provider networks, and health policymakers. While obtaining feedback from our community stakeholders, we're developing tailored interventions designed to have a sustainable impact on cardiovascular disease in Baltimore. Our center is going to conduct 3 separate studies. Our first study takes place in 6 clinics in Baltimore City and examines organizational characteristics of blood pressure measurement in these clinics and makes recommendations to reduce disparities in health outcomes among the patients there. We will improve blood pressure measurement at these clinics, introduce a care management program for patients, and a provider education system that improves patient-centered care. The second study actually engages patients, family members, and community members to improve blood pressure control of African Americans by providing them with problem-solving skills and communication skills that will help them better self-manage their illnesses and participate in decision-making with their doctors. The third study is designed to improve the patient's ability to obtain the nutrients needed to lower blood pressure. One of the ways to obtain these nutrients is through a diet called Dietary Approaches to Stop Hypertension, or the DASH diet. The DASH diets are low in sodium or salt and also rich in fruits and vegetables and low fat or non-dairy products. Another way to obtain these nutrients is through a supplement pill, and the study will assess whether counseling about the DASH diet, written materials about it, or the supplement pill will result in better control of high blood pressure. Our center also includes training, mentorship, and summer research experiences for students, postdoctoral fellows, and faculty. In doing so, we will not only support our own research efforts, but also prepare the next generation of leaders in healthcare and science. Without the funding provided by NIH, this work would not be possible, so I thank all of you here today for being champions for NIH.